Kanski lecture series, and this is going to be the uveitis part 15 with the miscellaneous idiopathic chorioretinopathies, which is one of the very difficult topics to remember because these are all very confusing and almost same. So we will see how it goes. The condition described below are uncommon inflammatory disorders, principally involving the posterior segment. So one thing is important, that it is an uncommon disorders and these are usually idiopathic. Their etiology is unknown or incompletely understood. Other entities may be present with the similar clinical manifestation, and it is critical to exclude alternative diagnosis, including infection and neoplasia. The white dot syndromes constitute a subgroup with some features in common. There is a variation between the sources in the list of conditions falling into this category. So this is a white dot syndrome. Basically all of these are almost same, but with the sources are sometimes different. You can use MUDES, which is multiple evanescent white dot syndrome. There can be APMPPE, which is acute posterior multifocal placoid pigment epitheliopathy. Then there is a birdshot chorioretinopathy. Then there is going to be PIC, which is a punctate inner choroidopathy. Then there is going to be serpiginous choroidopathy, multifocal choroiditis, and panuveitis, and subretinal fibrosis and uveitis. So you have to remember all this. So certain central serous chorioretinopathy is considered in chapter 14. Then there is a multiple evanescent white dot syndrome, which is known as MUDES. MUDES, introduction. MUDES is an uncommon idiopathic disease of acute onset, typically occurring in a young adult females, with 25 to 50% describing a preceding viral-like illness. So before it, there can be a flu-like or viral-like illness before such kind of symptoms, and these are usually in the females and with the idiopathic onset time. Clinical features: common painless monocular blurring. So there can be the blurring of vision almost about 6:9 to 6:60. There can be photopsia, flashes of light. Less common floaters, scotomas, and dyschromatopsia. So there can be the subtle posterior uveitis in 50%. So posterior uveitis is very mild in a case of a MUDES, but in 50%. There is a posterior pole lesions. Numerous small 100 to 300 micrometer ill-defined deep gray white patches sparing the fovea, which has a characteristic orange granular appearance and a dull reflex. So basically in a case of a MUDES, the macula is usually spared, but it has a orange granular appearance, but rest the lesions are usually white gray and it is sparing the fovea. So you can see figure. So it's not macular fovea. 12.75A is showing multiple evanescent white dot syndrome. A is showing numerous macular lesions, which is giving a granular appearance. B is showing FA, arteriovenous phase. A is showing hyperfluorescent spots. So these are hyperfluorescent spots that you can see. And C is showing FFA of a different patient. And D is showing ICGA of a C patient. Next is what are the optic disc edema is usually present, occasionally present. Recovery occur over weeks, often leaving subtle residual signs. Recurrence occasionally 10% occurs. Next is visual fields, very important because it is very much related to blind spot enlargement syndrome. So in this case, the blind spot is also enlarged. Visual field: the blind spot is commonly enlarged with a temporal field defect. OCT may show inner segment, outer segment junction disruption, and dome shape outer retinal lesion. So they're going to be ISOS junction disruption, and they're going to be the dome shape outer retinal lesion. FAF, hyper autofluorescent spot corresponding to the macular lesions, are visible during active inflammation. FAF has been used to demonstrate subclinical lesion in a patient with only foveal granularity. So basically FAF is autofluorescence. You have not given any kind of fluorescein injection, but when you see in the filter lights, they are hyper autofluorescent spot. Fluorescent angiography usually shows subtle early hyperfluorescence of the dot with the late staining. So they're going to be the hyperfluorescence and late staining, vessel wall leakage, and late staining may be seen. Whereas ICGA is opposite, which show hyperfluorescent spots that are often more numerous than visible on a clinically or on FA. ERG show a transiently reduced A wave amplitude. So there is a wave amplitude reduction. EOG and visual evoked response abnormalities may be present. Treatment is generally not required as the symptoms and signs starts to improve spontaneously in most cases by 2 to 6 weeks. So no treatment is required. In rare cases, treatment is needed for the choroidal neovascularization. Next is acute idiopathic blind spot enlargement syndrome, which is very much in common with the mutes, but in this case there is only the blind spot enlargement. Acute idiopathic blind spot enlargement syndrome is a rare condition reported in young to middle-aged women. So it is also in a woman, but in the middle age. Features include photopsia and decreased vision with the blind spot enlargement and mild swelling. Recovery to normal and near normal without treatment is usual. Some authorities believe that IBIS is not distinct from the mutes. So almost it is identical to mutes. Acute posterior multifocal placoid pigment epitheliopathy, APMPPE. Introduction: APMPPE is a common bilateral idiopathic inflammatory disorder. So one thing important is these are bilateral and both genders are involved in APMPPE. It affects young to middle-aged adults of both genders equally. There is a viral prodrome in 1/3 and it is speculated to occur as a result of a cell-mediated immunity to viral antigen. So there can be the viral antigen and the cell-mediated immunity can occur into it. The exact pathogenesis is not known, but it has been suggested that inflammation at the level of choriocapillaries result in hypoperfusion and ischemia of RPE and photoreceptor. So there is an inflammation of choriocapillaries which causes the ischemia of RPE and photoreceptors. So it is a pigment epitheliopathy and which is multifocal and placoid. Associated cerebral vasculitis can occur but is uncommon and can cause stroke. So one thing, it has also a CNS involvement. So whenever there is a CNS involvement, it can cause stroke. Erythema nodosum and other systemic features of vasculitis have been reported. The clinical feature of APMPPE can be mimicked by other entities such as sarcoidosis and tuberculosis. So what are the clinical features? Subacute moderate visual impairment with central or paracentral scotomas and photopsia. So they're going to be visual acuity decrease, and they're going to be the scotoma, which is central paracentral, and they're going to be photopsia. The fellow eye is affected within a few days or week. Headache and other neurological symptoms are common and can commence many months after the disease onset. Anterior uveitis and vitritis are usually very mild. So in this case, the uveitis and vitritis are mild, but the fundus changes which show multiple large deep yellow white placoid lesion initially at posterior pole. So initially they are at posterior pole, they are multiple lesions, they are yellow white. Within weeks, the majority fade with residual RPE disturbance of various severity. Some retinal macular fluid may be seen. Vasculitis and papillitis are rare. So after that lesion resolve, it can lead to the RPE pigmentations. So let's see figure 12.76a is showing acute posterior multifocal pigment placoid pigment epitheliopathy. A is showing fundus appearance. You can see multiple placoid type lesions, yellowish white, and B is showing angiography. Early venous phase showed dense foci of hypofluorescence. So in a case of a APMPPE, there is going to be the early hypofluorescence and then hyperfluorescence. So it is a hypofluorescence. FA showing late phase showing hyperfluorescence. ICGA show focal hypofluorescence. The prognosis: the visual symptoms and retinal appearance typically improves within weeks, and the long-term prognosis for the patient is good. However, these appearance appears to be subgroup of a patient whose symptoms may recur and who have a longer period of disease activity. So longer the disease activity, there is going to be the longer it is going to recur. In 25%, visual recovery is limited to 6/15 or worse as a consequence of RPE and photoreceptor damage to fovea. So whenever there is a fovea damage of RPE and photoreceptor, the visual acuity is 6/15 or worse. So what are the investigation? Alternative diagnosis should be excluded. HLA-B7 and HLA-DR2 are associated in the substantial proportion of the patient. OCT of the macula, FA of the active lesion show tense hypofluorescence and late staining. So first, in this case, HLA-B7 and DR2 are associated with APMPPE, and OCT of the macula can be done, and fluorescent angiography show early hypofluorescence and then late staining. ICG demonstrate non-perfusion of the choriocapillaries, so it is hypofluorescence. CNS imaging and lumbar puncture should be performed in a patient with the neurological symptoms. So treatment is basically not required, but we can give steroid in the case of cerebral lesions, especially vasculitis. Treatment is usually not required, but steroid should be considered for the patient with macular involvement. Steroid and possibly cyclosporin may be given for cerebral vasculitis. Patient should be instructed to seek medical advice urgently if neurological symptoms occur. Then there is a serpiginous choroidopathy, which is very similar to the tuberculosis. Introduction: serpiginous choroidopathy choroiditis is usually bilateral. It is also bilateral like APMPPE. Asymmetrical inflammation occur in the outer retina and choriocapillaries. So in that, APMPP inflammation was occurring in the choriocapillaries. In this, the outer retina is being affected, which is basically beneath RPE to the outer plexiform layer. And choriocapillaries, it typically occurs in middle age, affects men more frequently than women. So men are affected. Men are like serpents, you can say. So that is why it's more common in men, and is associated with HLA-B7. The disease is generally recurrent over years with a relatively poor prognosis. TB uveitis can give a similar clinical picture, serpiginoid. Next is, what are the clinical features? Initially, unilateral blurring of a central vision, scotoma and metamorphosia. So there is a blurring of a central vision, there can be scotoma, there can be metamorphosia. Anterior uveitis and vitritis are common but mild. So like APMPP, it can occur, but it is usually mild. Fundus show active lesions are grey white and remain active for several months before becoming scalloped and atrophy. So whenever there is active lesion, they are grey white, and they become, after several months, they become atrophied and scalloped. The disease typically starts around the optic disc and extend gradually through a variant starting at a macula. So a variant starting at the macula, 5% is recognized. Usually along the optic disc, these occur along the vessels, but it can also occur in the starting from the macula. Recurrence is usually contagious with or adjacent to existing area, eventually resulting in extensive chorioretinal atrophy. Complications: so there is a lot of atrophy going on. There is going to be CNV formation. There is 15 to 35% of the chances of CNV. There can be subretinal fibrosis. There can be the preretinal neovascularization due to ischemia. So let's see figure 12.77. So this is a serpiginous choroidopathy. A is showing early active disease. You can see the white lesion along the optic disc, and B is showing extension around the macula in a typical snake-like fashion. So C is showing advanced scarring, so lots of inflammation has occurred, and D is showing FA late hyperfluorescence. So TB should be excluded, especially in endemic area. FA of the active lesion show early hypofluorescence and late hyperfluorescence. So like APE, it is also show early hypofluorescence and late hyperfluorescence. ICG of active lesion reveals marked hypofluorescence throughout all the phases of angiogram. Treatment: oral or intravenous steroids may control activity. A variety of immunosuppressive and infliximab may be affected alone or in combination. So these type can also be given as steroids in this case of a serpiginous choroidopathy. Next is the relentless plecoid chorioretinitis. This refers to a rare entity showing features of both APMPPE and serpiginous choroidopathy, and is also referred as a empygenous choroiditis. So when there is both the feature of APMPP and serpiginous, this is known as a relentless plecoid chorioretinitis. Then there is a persistent placoid maculopathy. This rare condition features lesions similar to that of a macular variant of serpiginous choroidopathy, but which generally behave in a more benign fashion unless complicated by CNV. So it is like a macular serpiginous choroidopathy, which is known as persistent placoid maculopathy, but it is less mild than that of a serpiginous. Acute macular neuroretinopathy (AMN). AMN is a rare self-limited condition that typically affect the healthy young adult females. So these occur in females. The disease may affect one or both eyes and may be preceded by a flu-like illness. So there can be the viral prodrome. Symptoms consist of decreased vision and paracentral scotoma. So paracentral scotomas are very common. Red-brown wedge-shaped lesions are observed in a flower pattern arrangement around the central of the macula. So let's see figure 12.7a. So this is a acute macular neuroretinopathy. So there is a reddish brown lesion that usually occur around the macula in a uh, flower pattern arrangement. So you can see this is a fovea, and you can see that these are the reddish brown shaped lesion, wedge like lesion that occur around the fovea. In the corresponding to the scotoma, FA is normal or show faint hypofluorescence. Symptoms and signs slowly fade slowly over month and visual recovery occur. Then there is acute zonal occult outer retinopathy, which is known as azure. The acute zonal outer retinopathies are a group of a rare condition characterized by acute onset of loss of one or more zones of visual field. So whenever there is a loss of visual fields, this is known as azure, often temporal, in one or both eyes of a young or middle-aged female, some of whom have an antecedent viral-like illness. So there can be the viral prodrome and usually occur in females. So flu, females, and focus loss, like they're going to be the visual field loss, especially temporal. Photopsia and mild vitritis are frequent, and subtle vasculitis is sometimes seen. So vitritis is very common. The mechanism is unknown. Acute zonal occult outer retinopathy azure is the most common form of the azure syndrome and is characterized by minimal fundoscopic signs early in the disease course. The other postulated members of the group have more evident finding. Field loss may progress and recovery is infrequent. So field loss is one of the commonest feature. Later finding include RPE clumping and vascular attenuation in the involved area. So which area is involved is causing the RPE attenuation and RPE clumping and vascular attenuation. And peripapillary region, although the fundus may remain normal, OCT, FA, SCG, and FAF may demonstrate abnormality. ERG is important for diagnosis. So very important in the case of azure is ERG, characteristically showing A wave and B wave amplitude reduction and delayed 30 hertz flicker. Cones tend to be affected more than rods. So in a case of ERG, they are going to be the decreased A wave, B wave amplitude, and they are going to be the delay in the 30 hertz flickers. EOG show absence or severe reduction of the light rise. Stabilization occur within 6 months and up to 90% of the patient. Final visual acuity is 6/12 in at least one eye in most cases. Recurrence is sometimes seen. There is no proven treatment, although there are reports of favorable outcomes from the systemic steroids. So you can see this is azure. A is showing FAF, showing hyperpigmentation, nasal to the disc, and note the abrupt transition between the abnormal and the normal retina. So there is a hyperpigmentation along the nasal region. OCT image of showing a serious retinal detachment. So there is a retinal detachment in the case of azure. Next is a punctate inner choroidopathy, which is known as a PIC. So these are now PIC, MFC are going to affect the myopic females. So PIC, it typically affects young myopic women. Both eyes are frequently sequentially involved. It has similarities with LCP, but involvement predominantly involves the macula. So it is like MCP, but in the pic it involves the macula mostly. It is sometimes recognized with MCP or possibly subretinal fibrosis, uveitis, as pseudo POHS. So it is also known as a pseudo POHS with the PIC plus MFC plus SFU. So clinical features are sometimes blurring, floaters, photopsia, anterior uveitis, and vitritis are usually absent or mild. So vitritis are in this case is absent or mild in PIC. Several small yellow-white macular spots with fuzzy border at the level of inner choroid and retina. So in the case of inner choroid and retina, they're going to be the macular spots. Sometimes with an overlying serious sensory retinal detachment, these evolve into the sharply demarcated atrophic scars with little pigmentation similar to the histospots of a POHS. So 12.80 का A है. This is A is showing active lesion. There is also a suspicion of choroidal neovascularization superior to the fovea. So there is a whitish lesions around the fovea. B is showing the same eye as 2 weeks later, showing clear choroidal neovascularization. So you can here see the choroidal neovascularization clearly. So there is a several small yellow-white macular spots. So there is a macular spots that is yellow-white, and they're going to be the overlying serous retinal detachment. They evolve into the sharply demarcated atrophic scar with little pigmentation similar to histospots of the POHS. Prognosis: central vision may be compromised by the lesion at the fovea or commonly by the CNV up to 40%. So CNV is very common in a case of a PIC, which is about 40%. Investigations: FA show early hyperfluorescence and late staining of the lesion and demonstrate CNV. Treatment is with anti-VEGF medication should be considered for a choroidal neovascular formation in the macular region. Steroid and systemic immunosuppressive therapy can be helpful in the management of a recurrent CNV. Then there is a multifocal choroiditis and panuveitis. So there MFC or MCP. Introduction: MCP is an uncommon, usually bilateral but asymmetrical, chronic and recurrent disease that typically affect young and middle-aged adult females. So this also occur in the adult females. So this is showing a PIC. C is showing FA arterial phase of a different eye, showing several hyperfluorescent spot with hypofluorescent edge inferior to the fovea and lacy hyperfluorescence at the fovea, including choroidal neovascularization. FA late phase of the eye, C showing discrete hyperfluorescent spots and intense hyperfluorescence at the fovea. So we are discussing about the MFC along with PIC and SCFU. It is sometimes termed pseudo POHS because after leaving the atrophic scar is like the POHS. Clinical features: sometimes symptoms consist of blurring, floaters and photopsia, anterior uveitis 50%. Vitritis is also common. Fundus: multiple discrete ovoid yellowish gray lesion 50 to 350 micrometer in diameter at posterior pole or periphery, sometimes with linear cluster or streaks. Inactive lesions have a sharply defined margins and pigmented borders. Resembling POHS. So basically it is also showing a multiple yellowish gray lesion at the posterior pole or periphery with a linear clusters or streaks. Peripapillary atrophy may be seen. The course is prolonged with the development of a new lesions and recurrent inflammatory episodes. CNV occur in 25 to 35% cases, like in PIC. CMO and subretinal fibrosis resembling SFU can develop. Optic disc edema and blind spot enlargement may be present. Investigation, visual field may show large defect not corresponding with the examination finding. FA, early hypofluorescence and late hyperfluorescence. So it also showing us the MFC is also showing us a early hypofluorescence and a late hyperfluorescence. So we have studied early hyperfluorescence and late hyperfluorescence in the AP, MPPE in a case of serpiginous and now MFC. So you have also studied serpiginous, early hyperfluorescence and late hyperfluorescence, and now we have studied an MFC. Old inactive lesion show window defect. If the neovascular membrane develop in the macular region, hyperfluorescence is seen due to leakage. ICGA show hypofluorescent acute lesion which may be clinically apparent. Old lesion remain hypofluorescent throughout. ERG remains normal until there is an advanced retinal atrophy. Treatment: systemic and local steroids. Steroid resistant patient required immunosuppressive therapy. CNV is treated with steroids and anti-VEGF agents. So these are MFC is treated with the steroids, local or systemic. So this is a coronal neovascularization in multifocal choroiditis with uveitis. A is showing inactive lesions. B is showing early phase venous fluorescent angiography showing variable and hyperfluorescence of the lesion and lacy hyperfluorescence at the fovea indicated choroidal neovascularization. So this is a lacy pattern. Late phase showing hyperfluorescence at the fovea due to leakage from the choroidal neovascularization membrane. So in late phase show leakage. Then there is a progressive subretinal fibrosis and uveitis syndrome, SFU. SFU is also known as diffuse subretinal fibrosis. So there is going to be the fibrous formation, like a fibrous thickening contraction of the subretina area. Is an extremely rare condition. It typically affects the myopic young woman, causing gradual blurring of vision in one, then both eyes. Anterior uveitis and vitritis accompanies subretinal mounts at the posterior pole and mid periphery, progressing to widespread subretinal fibrosis. So there is going to be the mount formation, and then after that there is going to be fibrosis. Steroid may be effective early in the disease, but the prognosis is poor. Some experts view SFU as a part of a spectrum with MFC, MCP, and PIC. So this is a progressive subretinal fibrosis and uveitis syndrome. A is showing early, B is showing advanced disease. Next is a birdshot retinochoroiditis, one of the very common disorders. Birdshot retinochoroiditis is an uncommon idiopathic inflammatory disease, typically affecting the middle-aged woman. So it is affecting the middle-aged woman also. It is chronic, it is bilateral and manifests with the severe retinitis and stromal choroiditis that are independent inflammatory events. So there are going to be the retinitis and choroiditis as well. Nearly all the patients are HLA-A29 positive. Very important. Clinical features include symptoms: insidious impairment of central vision associated with photopsia and floaters. Vitritis is present in either or both eyes, so vitritis is a feature. Fundus show multiple ill-defined or void cream-colored choroidal patches less than 1 disc diameter in size in the posterior pole and mid-periphery. So you can see that there is going to be the multiple ovoid cream colored lesions less than 1 disc diameter in the posterior pole. The lesion often appears to radiate outward from the disc, usually spares the macula. So macula is usually spare itself. Inactive lesion consists of a well-defined atrophic scar, CMO, epiretinal membrane, and CNV may develop. Visual field testing, not visual acuity, is the appropriate functional test for the monitoring disease evolution and response to treatment. Prognosis is about 1/3 of the patient have eventual best visual acuity of less than 6/60. However, results are starting to improve with aggressive and sustained immunomodulatory treatment. Choroiditis respond well to this treatment, but the retina less so. Next is investigation. HLA-A29, over 95% of the patient are positive. OCT will confirm macular edema. Autofluorescence will generally show numerous hypoautofluorescent lesions that are seen on examination. So, autofluorescence was your hypoautofluorescent. FA show extensive vascular lesion with disc and vessel staining and show diffuse macular edema. So this is a birdshot retinochoroiditis. A is showing active disease, B is showing inactive lesion, C is showing late phase fluorescent angiography showing disc and vessel leakage, vessel wall staining. D is showing, so there is going to be the disc and vessel wall staining and vessel wall leakage as well. Early phase indocyanine green angiogram show numerous hypofluorescent lesion. Strikingly, the fovea is often spared and the cystoid macular edema is less common, 15%. ICGA lesions are more numerous. These are hypofluorescent during early and intermediate phase and isofluorescent later. They do not correspond to the retinal lesions. So theirs are usually hypofluorescent in early and intermediate phase and isofluorescent in the later phase. ERG is normal in early disease but with the time show rod and cone abnormalities. Tip: HLA-A29 histocompatibility antigen is present in almost 100% of the patient with birdshot retinochoroiditis when PCR methodology is used. Treatment: the first step is to use subtenon triamcinolone acetonoid 40 mg, particularly in patient with a monocular disease. So you can give a subtenon triamcinolone because there is a vitritis going on. Up to 90% of the patient needs systemic treatment. Early referral to a uveitis specialist should be considered. Systemic steroids are used initially, but immunomodulatory treatment is often needed, usually mycophenolate followed by infliximab. So you can also give the systemic steroids and systemic treatment as well. Then there is acute retinal pigment epitheliitis, which is known as ARPE. ARPE, krill disease, is a rare idiopathic self-limited condition of RPE. So this is a condition of the RPE which is usually self-limiting. It is usually unilateral. 75% of the cases presentation is with young adults with a mild disturbance of a central vision. 1 to 2 weeks of onset of the symptoms, the macula show 2 to 4 discrete cluster of the subtle small 1/4 disc diameter gray spot at the level of RPE surrounded by a hypopigmented yellow halo. So there is a gray spot that is surrounded by a yellow halo. So let's see figure 12.84. So A is showing acute retinal pigment epitheliitis. So you can see there is a yellow halo and a gray white spot at the center. B is showing FA venous, is showing corresponding focal hyperfluorescence. Over 6 to 12 weeks, the lesion resolves and vision returns to normal. Recurrence are common. OCT show hyperreflectivity at the photoreceptor outer segment layer. So outer segment will show hyperreflectivity. A fish may be normal or the spot may show hypofluorescent center with a hyperfluorescent halo. So the spot will be hypofluorescent where the halo will be hyperfluorescent. The EOG is subnormal, treatment is not required. Unilateral acute idiopathic maculopathy. Unilateral acute idiopathic maculopathy is a rare self-limited condition that is most frequently unilateral and may be preceded by a flu-like illness. So there can be a flu-like illness. Patients are young adults who describe marked reduction in central vision. So central vision is markedly reduced because it is a maculopathy. A viral prodrome is common and associated systemic infection has been noted. And irregularly yellow or gray exudative retinal detachment is seen at the macula. So ERD is also seen at the macula, associated with small hemorrhage and papillitis. Within few weeks, the exudative changes resolve. The bull's eye appearance may develop following resolution and can be associated with persistent visual loss. Bulls like maculopathy can also be developed. So let's see figures 12.85 A and B. So it is showing acute idiopathic maculopathy. A and B is showing the development of the macular sensory retinal detachment over the course of month. C is showing bullseye appearance of a further month. FA show hyperfluorescence of a subretinal fluid. So first there is going to be the retinal detachment, then there is the bull's like lesion. OCT show hyperreflectivity at the photoreceptor outer segment layer and RPE thickening. So RP is going to be thickened and photoreceptor outer segment is showing the hyperreflectivity. FAS shows tripled hyper autofluorescence that become hypofluorescent. So first there is going to be the hyper autofluorescent that is going to become hypofluorescent in a case of FAF. FA show early irregular mild hypofluorescence at the detachment with the subsequent intense staining. Treatment is usually not given. Then there is acute multifocal retinitis. Acute multifocal retinitis is a very rare self-limited condition that may be preceded by flu-like illness, which is possibly an atypical presentation of a cat scratch disease. So it is also associated with the cat scratch disease. It causes sudden onset of mild visual loss in a young adults. Multiple area of retinitis are seen posterior to equator. So usually it is posterior to the equator. Along with mild vitritis, so they're going to be mild vitritis as well. They're going to be disc edema and sometimes macular scar. Recovery occur over 2 to 4 months. Treatment as for cat scratch disease may be considered. So let's see figure 12.86 has showing acute multifocal retinitis. Next is there is a solitary idiopathic choroiditis, SIC. Solitary idiopathic choroiditis is a rare entity that presents with a mild visual loss or is asymptomatic and discrete posterior post-equatorial dull yellow choroidal elevation with ill-defined margin is seen. So there is going to be the choroidal elevation with a vitritis is seen. During active disease, contagious subretinal fluid and macular scar may be present. With healing, the lesion develop a better defined margin. So when it is healed, has a better defined margin with resolution of the subretinal fluid and exudation. Treatment of vision-threatening lesion is with the systemic steroid. Next is the frosted branch anginitis, which is usually caused by, which is primary and secondary as well. And the primary is due to idiopathic cause, and secondary may be due to some other conditions like CMV. FPA describe a characteristic fungus picture, usually bilateral, and may represent a specific entity, primary or a common pathway in response to multiple stimuli. Secondary FPA may be associated with infectious retinitis, notably cytomegalovirus retinitis and other conditions such as lymphoma and leukemia. So remember, if primary occur idiopathically, secondary occur with some kind of disease. Primary idiopathic FPA is rare and typically affect children and young adults in whom presentation is with bilateral visual loss 632 PL. Floaters and photopsia, there may be a viral prodrome. Florid sheathing of a retinal arterioles and venules are seen. So retinal arterioles and venules are doing florid sheathing. Anterior uveitis, vitritis, and retinal edema are common. Treatment is with systemic steroid, though some authorities believe the prognosis, which is usually good in the primary form, is unaffected. So you can give the systemic steroids in this. So let's see figure 12.87, which is showing the florid sheathing of the arteries and venules. So frosted branch anginitis in a patient with lymphoma. So next is the idiopathic retinal vasculitis, aneurysm and neuroretinitis syndrome, IRWAN. So there is going to be the retinal vasculitis, there are going to be aneurysms and neuroretinitis. Idiopathic retinal vasculitis, aneurysm and neuroretinitis syndrome is a rare entity that typically affects one or both eyes of a healthy young woman. Fundal sign consists of arthritis and multiple aneurysm dilators of arteriolar branches and on the optic nerve head together with anterior uveitis and vitritis. So it consists of arthritis, there are going to be multiple aneurysm dilatation of arteriolar branches and on the optic nerve head, and there can be anterior uveitis and vitritis. So there is a arthritis and there is a aneurysm formation. Disc edema and macular scar neuroretinitis are common. Marked macular and circumpapillary exudative retinopathy can develop. The vascular changes are demonstrated very well on FA. Extensive peripheral capillary non-perfusion may lead to pre-retinal neovascularization, and early pan-retinal photocoagulation should be considered. Intravitreal anti-VEGF treatment and steroid have been associated with a good result in some patients and may be given in a combination. So you can give anti-VEGF and steroids in the case of a pre-retinal neovascularization. So let's see 12.88 showing idiopathic retinal vasculitis, aneurysm and neuroretinitis syndrome. A is showing succinate pattern of hard exudate surrounding the disc. There is also a venous irregularities and obscuration of the optic nerve head. FA show multiple aneurysm of the arteriolar bifurcation and marked variation in arteriolar caliber. So that's it for the uveitis. See you in the next lecture series.